Alright, in this video we will be discussing about the gait disorders or disorders of gait. Gait disorders are read under the system of neurology, and we will be discussing another topic in our continuing series of symptomatology of neurology. We are basically discussing symptomatology of neurology, and gait disorder of gait is another symptom with which the patient presents to the OPD or the emergency, and that is why this is a symptom of neurology, and we are discussing this in the symptomatology. uh, as far as definition of gait is concerned, gait means how a patient walks, how a person walks is basically gait. And disordered gait means there is some neurological deficit and there is some functional adaptation by the patient in order for him to walk properly. I mean, not properly, but in order for him to walk easily, as easy as possible. So there is some functional adaptation also, right? And these two phenomena, when they combine, they result in a certain gait. And when we see clinically gait, we have to keep in mind these two possibilities, that there will be a neurological deficit, as a consequence of which the patient must have adapted himself to walk in some certain fashion. These two phenomena, when they combine, they will form gait, right? Now, going on further, what is the prevalence of gait disorders? See, gait disorder prevalence increases with age, maybe because of arthritis, maybe because of cerebrovascular accidents, maybe because of some fracture, maybe because of some neurological problem of peripheral nerve, maybe because of sciatica, or whatever the cause. We know that neurodegenerative causes or otherwise degenerative diseases, they increase with age, their prevalence increase with age. That is why with increasing age, the prevalence of gait disorder also increases. Gait disorder is present in 15% of individuals, in individuals who are more than 65 years, and it is present in 40% of individuals when they are more than 85 years. So there is correlating increase in prevalence with age. Coming on to next slide, what is the anatomy and physiology of walking, or anatomy and physiology of maintenance of gait and posture? We are discussing the anatomy and physiology of gait, movement, posture, right? So first thing is step generation. See, step generation is different in primates and it is different in other animals. In primates, it is dependent on locomotor centers in the pontine tegmentum, midbrain, and subthalamic region, right? Whereas in lower animals like cats, dogs, the locomotor generators are present in spinal cord. But in humans and other primates, these locomotor generators are present in pons, in midbrain, and in subthalamic region. Then locomotor synergy. Synergy is executed through reticular formation and in ventromedial spinal cord. Spinal cord and reticular formation is responsible for synergy, right? And synergy, by synergy we mean the coordination of movement, coordination of steps, right? It is basically generated by reticular formation and ventromedial spinal cord. What is the function of cortex? Cortex means higher functions. Cortex means your thought, your cognition, right? How is cerebral cortex involved in anatomy and physiology of gait? Cerebral cortex will provide a goal and purpose of walking. Why are you walking? How are you walking? How fast will you walk? When will you reach the goal? Right? All this is pre-decided by the cerebral cortex, and cerebral cortex will manipulate the lower generators and lower areas in the formation of gait and maintenance of gait and posture. It helps in avoiding obstacles and it helps to adapt to the terrain, right? If the terrain is not even, or if the terrain is even, we will change our stance and change our gait accordingly. That is mediated by cerebral cortex, because cerebral cortex know that what is going to come next, right? So it somehow controls the lower pathways and it somehow manipulates the gait. Now control of posture. How posture is controlled? Control of posture means the maintenance of center of mass over the base of support through the gait cycle, right? Maintenance of center of mass over the base of support through the gait cycle, right? We prevent ourselves from falling. We maintain our posture by maintenance of center of mass over the base of support. Vestibular nucleus and midline cerebellum contribute to balance control in animals, right? We have to remember these two centers for postural control: vestibular nucleus and midline cerebellum. Of course cerebellum is involved in maintenance of posture, but remember midline cerebellum. The peripheral cerebellum is involved in coordination and other functions, but the axial postural control is 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 maintained by midline cerebellum. Sensory information for postural control is generated by the visual system, vestibular system, and proprioceptive receptors in the muscle spindles and joints. This is very important concept. Very important concept. I would say everyone must know this. Everyone must know this. Sensory information for postural control. See, we maintain our posture by gathering information from different peripheral sensations, right? We gather information from the visual system, we gather information from the vestibular system, and we gather information from our proprioceptive receptors which are present in muscle spindles and which are present in joints, right? All this sensory information will be coordinated by the cerebellum, and cerebellum will decide that how is it going to control the posture. So sensory information, how sensory information reaches the cerebellum? We we read this concept in the in the previous video, in which we studied about the dorsal column. The dorsal column carries the proprioception. It carries other sensations also, like vibration and joint position sense. So proprioception is carried by the dorsal column to the cerebellum and thalamus, right? So the cerebellum will gather this information, and it will coordinate this information, and it will tell the muscles to gain a certain posture. But what happens is that if there is loss of two out of these three pathways, right? What are the three pathways? Let me highlight it because it is again very important. See, first is the visual system, second is the vestibular system, and third is the proprioceptive receptors. These three are the sensory afferents. These three sensations are carried to the cerebellum, right? First is the visual symptom, second is the vestibular system, third is the proprioceptive receptors. These three sensations are carried to the spinal cord, or to the cerebellum, and they say that loss of two out of three pathways is sufficient to compromise standing balance, right? Suppose your dorsal column is involved as well as your vestibular is involved. These two are, if these two are involved, there will be loss of balance. But this very rarely occurs. uh, Either the cerebellum will be involved in cerebrovascular accidents, or you can say that dorsal column will be involved. Both can never occur together, right? If cerebellum is involved, there will be loss of posture, there is no question in that. But if there is dorsal column lesion, right, dorsal column is involved, if dorsal column is involved, if dorsal column is involved, and you close the eyes of the patients, means two sensations are gone. One is the dorsal column carries proprioception, this thing. Dorsal column carries the proprioception, and eyes will carry the visual system. So these two sensations are compromised, these two sensory pathways are compromised, and it is written that two of the three pathways, if two of the three pathways are lost, it is sufficient to compromise the balance. And if the patient falls or tends to fall on closing the eyes, means the dorsal column is already gone, means this is Romberg sign positive. That is what I want to tell you here. Romberg sign. I want to tell you here is the Romberg sign. What is Romberg sign? What is the physiology behind the Romberg sign? Right. So coming on to the next slide. These are the disorders of gait. Different disorders of the gait. There are the different names of the gaits. Right. We will be reading them one by one. First is the cautious gait. Cautious gait is not just it is not a disorder in itself. It is just that the patient fears to fall, like, right. The term cautious gait is used to describe the patient who walks with an abbreviated stride, widened base, lowered center of mass, as if walking on a slippery surface. The patient is fearful while walking, right. The cause is idiopathic, and it may also be associated with fear of falling. Either the patient is fearful of falling, or it is idiopathic. Some patients walk like this only, we have no explanation for that. So this is the first gait that we have discussed. Second is the spastic gait. Spastic gait is it is definitely a consequence of, it is definitely a consequence of some neurologic deficit. It is characterized by stiffness in the legs, imbalance of muscle tone, right, uh, and a tendency to circumduct and stuck scuff the feet. The cause is UMN lesions like in stroke, MS, cervical myelopathy, and dystonia. We have to understand the cause. Once we understand the cause, we will be able to make out that why this kind of gait is occurring. You know that in stroke, MS, there will be upper motor neuron lesion. If upper motor neuron lesion is there, the tone of the muscles will increase. Tone of the muscles will increase, it will cause spastic gait. That's all. Now, third thing is the fascinating gait, shuffling gait, and freezing gait. This kind of gait is seen in Parkinson disease, right? There is difficulty in starting the movement. There is difficulty in turning around, right? There is difficulty in there is difficulty in stopping, right? Fascinating gait means there will be small steps, small rapid steps. Shuffling gait means again there will be small rapid steps without the movement of arms, means no arm swing. Freezing gait means difficulty in initiating the gait. These three types of gait are found in Parkinson disease, right? Now, what is the frontal gait? Frontal gait is also known as higher level gait disorder. We have discussed how many gaits? 3, 4, 5. This is the sixth gait, frontal gait. Frontal gait is also known as higher level gait disorder. It is used to describe shuffling, freezing gait, with imbalance and other signs of higher cerebral dysfunction. The term lower body Parkinsonism is also used to describe such patients. The most common cause of frontal gait disorder is vascular disease. Which vascular disease? Small vessel disease, not stroke. Means stroke, but small vessel stroke, not the classical ischemic or the major vessel in involvement of stroke. It is small vessel stroke which is very long standing, very subtle, and the patient will come to you with certain gait disorder. Then you have to assess, and you have to be suspicious at that time that okay, there can be some uh, small vessel involvement in the deep frontal white matter and centrum ovale, right. So this is the type of gait that we find in small vessel disease. Cerebellar gait ataxia. Again, cerebellar, it explains in itself that when cerebellum is involved, the gait which occurs as a result is the cerebellar gait. It is characterized by a wide base of support, lateral instability of the trunk, erratic foot placement, decompensation of balance when attempting to walk on a narrow base. Very important. Every word of this line is important. When you will clinically examine a patient of cerebellar lesion, you will you will see every finding that is written in this line. The patient will not be able to walk on a narrow base, right? You will tell the patient to walk on a line, he will not be able to walk on the line, he will fall when he will try to walk on a line. Erratic foot placement will not be regular. Lateral instability of the trunk, the trunk will sway around, right? There will be a wide based gait will be there. What are the causes? Causes is alcohol, which is very common. Causes is stroke, causes trauma to the cerebellum, means posterior head trauma. Then neurodegenerative diseases like MSAC, multisystem atrophy with cerebellar involvement. Right, this is cerebellar gait ataxia. Now the sensory ataxia. The stance in such patients is destabilized by eye closure. They often look down at their feet when walking and do poorly in the dark. That is what we have discussed in the Romberg sign. That that I took a lot of time to make you understand that what is Romberg sign. Romberg sign means when a patient of dorsal column lesion will present to you with gait disorder, you will tell him to close the eyes and you will tell him to walk, or you will just tell him to close the eyes. As soon as you close the eyes, the patient will tend to fall on a side, on left side or on the right side, and the lesion of the lesion will be on the same side of the lesion will be on the same side of the cerebellum or on the of the dorsal column, right? Means when there is dorsal column involvement and you close the eyes of the patient, two out of three sensory pathways are compromised, and two out of three pathways are sufficient to imbalance, to make the patient imbalanced, to make the patient lose his control of posture. Like, so whenever a patient of Tabes dorsalis or vitamin B12 deficiency myelopathy presents to you, right? Tabes dorsalis means syphilis, neurosyphilis. Tabes dorsalis means neurosyphilis. Whenever a patient of neurosyphilis or vitamin B12 deficiency myelopathy, basically myelopathy, by myelopathy, I particular I particularly mean to say dorsal column. When dorsal column is involved and you close the eyes of the patient and the patient falls, it means the Romberg sign is positive. Sensory ataxia. This is sensory ataxia. Now, neuromuscular disease. In peripheral neuropathy, step height is increased to compensate for foot drop, yes, and the sole of the foot may slap on the floor during weight acceptance, termed the steppage gait. Steppage gait, or also known as stomping gait. This is seen in peripheral neuropathy. Right. So that is all about the types of gait. How many types of gait we have discussed? Frontal, then cerebellar, then comes this sensory ataxia, then comes this neuromuscular. Right. We have discussed 9 types of gaits. I hope you have learned something from this video, and you can go through this video again and again, because this is gait disorders and these are the types of disorders, gait disorders only, and they will be asked a number of times, multiple number of times in your practicals, in your theory final exams, and even in your residency. You must know that what are the types of gait, especially this Romberg sign, that what is the physiology of Romberg sign, why it occurs, because it will cover the whole of the basic knowledge. If you know the basics of the anatomy and physiology of the maintenance of gait, you will be able to understand the Romberg sign. And Rest all is about cramming the types of weights, their names, and yes, if you see the patient you will be able to remember it easily because you have already seen the patient. So that is all about this video. Thank you so much for your patient listening. That's all.